Okay, well, welcome everybody. We're going to go ahead and get started. I want to introduce our first speaker today, Dr. Robert J. Esterhay. He has a research interest in networks for health and in network participation theory as it applies to individuals, organizations, and networks themselves. Dr. Esterhay has been at the informatics crossroad of individual health, healthcare, and population health for more than 35 years in his education, work experience, and academic setting. He is Associate Professor and Chair of the Department for Health Management and Systems Sciences in the School of Public Health and Information Sciences here at the University of Louisville. In the mid-1970s, he led an early implementation of an electronic medical record information system at the University of Maryland Cancer Center, and in the mid-1990s, a nationwide implementation of an electronic medical record system in 60 long-term acute care hospitals and 300 nursing homes for Kindred Healthcare, which is formerly Vencor. Some of his accomplishments include taking the ideas and concepts for a cancer information system for the National Cancer Institute and creating NCI's PDQ, a comprehensive cancer database that continues to be used in the internet today, serving as a member of the Kentucky Telehealth Network Board, serving as the first co-chair of the Kentucky eHealth Board, analyzing community health information exchanges funded by the Kentucky Science and Engineering Foundation, and using the developed governance model to create the Louisville HIE. Please welcome Dr. Robert Esterhay.
Thank you very much. Since this is such a small group, I'm going to go through these slides. All these slides are represented in the book one way or another. So it's, you don't have to take notes. And so if there's any question anywhere, just raise your hand and I'll stop talking and we'll deal with your question rather than waiting to the end. So we'll just go and we'll have fun. I have a whole lot of slides. I have no idea if I can even get through all of them. I'm not even sure I need to get through all of them. So, and you're a very interesting group of people. When I got contacted about doing this, I was sort of like, who are you guys? What do you do and why? And I had no idea. And then I said, well, sure, I'll come and talk. But how about if I talk about population health rather than the Affordable Care Act, which is, I think, the initial interest. And I said, oh, and by the way, why don't you just buy a book for everyone? And by golly, you did. And so thank you very much for buying a book. It's the first book I've ever done. I'm not sure I would ever do it again. There are 27 authors, and if you've ever tried to manage 27 academic and industry type people who have full daytime jobs and they're writing chapters on the side, I would advise you not to do it. It's worse than herding cats. Anyway, population health. It's an interesting topic. I'm not sure everyone will agree what population health is. In the book, as you look on the cover, I tried to deal with three things simultaneously throughout the book, and that is management, policy, and technology. And you can't deal with all three because each topic area is so huge. So we try to focus in on some themes in the book, which are network leadership, and we'll have an interesting discussion about that. The idea of health in all policies. Just because you work in housing or transportation doesn't mean you shouldn't worry about health and health issues for your agency and for the customers you serve. And why should we promote wellness through systems and policy change? And what is technological innovation anyway? When I was in college and I wanted to use the computer, I don't know how many of you would even remember this, but I had a stack of punch cards and I had to go to the computer center, turn in my punch cards, and leave, and then come back maybe the next morning and find out that my job didn't run. And I had to do the punch cards over again. You know, sometimes it took many trips to just get a simple job run. Today, my grandson has an iPad and punches on the iPad. That darn iPad has more computing power than the college mainframe computer of many years ago. It's amazing what's happened. And it's changed how we think about things. It's changed how we do things. And there are new businesses that have been created that leverage the whole idea of the movement of information and data through networks. And so finally, what is the future of population health? And I'll get into that in a little bit. So what is population health? Well, if you look in the first chapter, there's a table in there where there's a whole bunch of people who've tried to define what population health is. And as most academics, they get into taking a position and getting very heated about what population health is. It means different things to different people. For your society, your population are the people that you interact with and your stakeholders. For a hospital, it's the patients that come to your hospital. That's the population or subpopulation you deal with. And one of you is in an intensive care unit here. I can't remember which one of you. But it's the population that's in the intensive care unit. That's your population, your subpopulation that you think about and that you worry about. So who you are, where you live, who you work for, defines how you think about population. If you're in a hospital, your population are the people that come to your hospital, or if you're an accountable care organization these days, it's the people that you have responsibility for, whether they're in the hospital, in an ambulatory setting, or even at home. And finally, Kindig has defined it as health outcomes of groups of individuals. So it's more like a study more than something that you're actively doing. Anyway, it doesn't have agreed upon definition, but you can think of population health as a complex ecosystem. And you can begin to think differently about how you think about the individuals that are your stakeholders or your customers and how you interact with them and how you deal with them. So this is a pretty Venn diagram, basically saying that we're all consumers of health as individuals. We have this big mammoth healthcare system in the country, which is responsible for most of the money we spend. We have traditional public health that worries about safety, the water you drink, the air you breathe, the ground, pollution, the safety of the restaurants you eat at. That's traditional public health. It's interesting that traditional public health has also been thought of as health care for the poor, primary care. We get a lot of students from foreign countries that come into our program, and in foreign countries, public health is really primary care. Whereas in the US, in large regional populated areas like Louisville, although traditional public health still does all the key things that it needs to do, it's less and less involved with primary care. And unless you're in a rural area, in which case public health may still be involved to some extent in primary care, but traditional public health is something that people get confused. They think of it as care for the poor. This is a big area right here, social policies. policies that are results of laws, regulations. This is where all the action is, right here. We don't think about it, but it really is. And they all interact with each other, and it is a very complex ecosystem. Another way of showing it is that the determinants, medical care, individual behavior, social environment, physical environment, even genetics, all lead to population health outcomes. And you have policies here that affect what happens here. And here we look at data. We look at a lot of data, and we look at population mean mortality and population mean health-related quality of life. Any questions?
So the data drives the healthcare policies?
Yes, ideally. In the book, in chapter 3, we talk about the use of health impact assessments, which most people don't know about. And you can use those to collect data to drive policy. And you ask a lot of questions. You find out who your stakeholders are. You get into the community and you say, you know, what are the really important things that we need to be concerned about? Who are all the people involved? What it is that we really need to do? And that assessment can lead to policy development. So you're collecting data to help establish policy. So that's a good question. So people within a given geographic region, stratified on the basis of demographics and statistical characteristics, are a way that you start to bring meaning into whatever population that you are studying, or you're dealing with, or you're providing information or services for. And the determinants of the health population are really social and economic policies for urban and rural communities, dealing with resource inequality. And we move to kind of, how are we going to measure the health of the population? And we have to rely on all kinds of different kinds of data to be able to do that. In the US, we talk about, maybe you've never seen population pyramids before. Pyramid would look more like this. But in the US in 2013, we don't have a pyramid. We have what looks like a trapezoid. And that's because we're getting older, and so it doesn't go up like this, it's going up like this. So our baby boomer population is going to hit somewhere between 70 and 90 million people. It's going to have a tremendous effect on population health. There are not enough nursing facilities, nursing homes to house everybody. We have a big problem. We all know about it. We haven't done anything about it really, but it's coming. Some people refer to it as tsunami that's just going to wash over us like we just can't believe. So we're going to have to figure out how to deal with that. The other couple things that are mentioned in chapter 4, 2 things are happening. One is that we have a minority population that's growing very rapidly. And all growth is under the age of 45, which is occurring in the minority population in the US. That has tremendous implications for how we deliver health care and how we think about health. And the fertility rates and immigration factors are the things that are changing the diversity more than you can believe. And we're living longer, as I pointed out in the population pyramid, and that has tremendous implications. Healthcare costs will go up dramatically, but with preventative care, we can address economic well-being throughout a person's life. We can deal with safety, safe and clean environment, a strong social network, and preventative health services over a person's entire lifetime. So, just to repeat, our population is becoming more diverse and we're living longer. So we need to understand the realities of this. And there's some important societal questions that have to be addressed. And is healthcare a public or private good or service? And you've heard the debate before. Is it a right or is it a privilege? Is it a privilege to breathe clean air? Is it a privilege to eat? What are the personal and societal responsibilities for good health in the population? We have some really interesting debates about this with our students, and we encourage, there's not a wrong answer or a right answer. There's just, this is the way it is. And how do you understand it? And how do you deal with it? There's another issue which I try to cover in the book, and that's the whole idea of complexity science. If you look at this figure, you can get agreement, you can get a high level agreement when you really have good plans and you have good control. You know, everything's specified, it's simple, it's straightforward. You understand the vision, you understand the mission, you understand the objectives and goals, what you're trying to do. On the other hand, where you have low certainty about outcomes and you have low agreement is when things get really messy, when things get chaotic. And there's this tension here between something that everyone can highly agree upon, which is kind of simple to understand, simple to execute, and something that's very difficult to understand because it appears to be a mess. And somewhere along here, patterns often emerge. And the idea is, can I recognize a pattern, which is something that arises out of the chaos that's going on, and look at that pattern and say, there's some order here. What is it, and how can I take advantage of it? And we refer to this like there's this zone of complexity. And the three things about the book are management, policy, and technology. And these things are interwoven. And when you get into discussions, there may be a management issue, but you're really trying to figure out what the policy is. There may be a technology issue, and you can't figure out what it is. So there is a complexity perspective in this whole area of population health. And we try to touch upon it in the book. I'm not so sure we did such a great job, but at least we introduced the idea. And the three themes in the book, which I referred to in the first slide, is this idea of network leadership, the idea of health in all policies, and the idea of technological innovation. We'll try and cover these going forward. Now, you also have to understand that all of this is occurring under what we call regulatory reforms. And the first is the stimulus effort that took place in 2009, high tech specifically, which is a name I can never remember. So I wrote it down. It's Health Information Technology for Economic and Clinical Health, or the High Tech Act. Is the idea that there would be money made available, whether you were taking care of Medicare patients or Medicaid patients, so much money per physician, more for Medicaid, less for Medicare, if in fact you could show that you met the criteria of using an electronic health record system. And that was stage one. Stage two is if you could use your electronic health record system and actually exchange information with other partners, called health information exchange. And the third stage, which we're not at yet, is the whole idea of patient engagement in their own health. And a lot of money, 19.9, whatever the number was, billion, being spent. And Kentucky's done a great job of getting a lot of that money for physicians and hospitals. Now, if you're a physician, you have to decide whether you're going to get money for Medicaid or Medicare. You can't do both, but hospitals can do both, which even makes it more confusing.
You brought up a very interesting point, Dr. Esterhay, because our network started with meaningful use, and we've had to pick up additional physician offices. We
Right.
also picked up other hospitals that could not implement the technology, just so they could be part of that network.
The point that's being made is that if you're going to go after the money, there's certain things you have to do. And the idea was, can I get other physician practices to buy an electronic health record system? Because you can't buy, with the stimulus money, you can't buy the electronic health record system. You have to buy it on your own nickel. But then you get money for using it. And most people don't understand that. A process called attestation, and you have to prove that you can do the criteria, and then you get the money. So, and a lot of people have been saying, boy, some of those people never really did all the things, but they got the money. So that game will play itself out. People don't realize that to be able to do the Affordable Care Act, it relied on this. How else could you get efficiency? If you get efficiency by driving down transaction costs, by moving information electronically and getting paid electronically, then you start to achieve efficiencies. You drop the cost of care, and by dropping the cost of care, then the Affordable Care Act works. But so this is not possible without this. They're intertwined. Everybody understand that? The neat thing about the Affordable Care Act is that it's basically insurance reform. And so children can stay on their parents' plan until age 26. There are many preventative services are free. They're not all free, but many are. Medicare prescription drug coverage is more affordable, and states can opt to receive federal funds for expansion of Medicaid.
But there were a lot of states that opted out.
Right. You want to say anything further?
No, I know you can elaborate on that, probably with more wisdom.
And I'm sure I have more wisdom. It's interesting, the states that did not opt in are now wheeling and dealing with CMS so they can get that money. Of course, they make up other names because they don't like the name Obamacare. In Kentucky, we didn't call it Obamacare. We call it Connect. It's okay to have Connect. It's not okay to have Obamacare. So the really funny thing is on the street, you say, well, what do you think of Affordable Care Act? Oh, I really like it. What about Obamacare? Oh, it's terrible. There are other states who are saying, across the river, it's Hoosier Health. It's okay to have Hoosier Health. And I suppose in Pennsylvania it's going to be called Keystone Care or something like that. I don't know what Florida's going to do. The governor's in a bad position because the hospitals are beating up on the governor and saying, our hospitals will close because our profit margins are so thin unless you adopt Medicaid. The governor's saying, no, 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 we're not going to do Medicaid. He tried to do it, and then his party backed him out of it. They will lose billions of dollars. Every state that does not invest in Medicaid will lose billions of dollars. It ends up being an economic decision.
What do you mean invest in? Because I know that we accept WellCare and Coventry and Visas programs
Right.
and stuff like that. We have to write off the copay now. We don't
Right.
do that anymore. So, but we still have Medicaid patients. Is that just a per practice thing then?
Yeah.
Okay.
Remember that under the ability to expand coverage, that happened because the poverty level dropped to 138%. So in Kentucky, they have 521,000 people now enrolled. 500,000 people who didn't have coverage before. So now they have a card and they can go and get care.
And they're coming to my office for their eye exams.
Right.
Yeah. That's super cool. 500,000 of them. Yeah.
Right. No, that's the downside.
Yeah, I know.
Not enough physicians, not enough primary care physicians. And then the state says, well, we don't really want nurses to practice medicine. But there was a law passed in Kentucky that allow nurses now to be able to stand up their own practice and see individuals. It'd be nice if you could do that with pharmacists. So the whole idea is as we move from a centralized model to a distributed model, and things that can be routinely done, simple things, straightforward things, can be done by nurses, physician's assistants, pharmacists, quite well. But the docs don't like that. Oh, you're taking away my dollars. So just remember, if you put a lot of money on the 50-yard line, everyone will show up. And no one wants to lose it. So, the thing about the Affordable Care Act, we've been talking about it, are the insurance exchanges. Some states stood up their own, like Kentucky, and did quite well. Some states tried to stand them up, and they didn't work. They failed. Oregon is suing Oracle, and Oracle is suing Oregon. Think of all the money the lawyers are going to make. It's a complex world. The idea of the exchanges is that it's a marketplace. It's like a grocery store. And you go to the grocery store and you have 26 choices of mustard. Which mustard do I buy? And to someone who doesn't understand how healthcare works, they go to the grocery store, they exchange, and they say, golly, I got all these options. Which one do I choose? Which one do I do? And for some people that deal with what we call health literacy problems, that they don't understand, or their culture is different, because they're a minority population, they just don't understand.
Can I tell you,
Yeah.
for somebody who's been a nurse for 35 years, how complicated this is?
Oh,
I did it in Oregon in between jobs, so I
Right.
had to go get insurance. So all of a sudden, I was one of those people.
Right.
And so I went on the exchange in Oregon, and there are so many choices. And I understand what I'm reading, but it was totally overwhelming.
And you have a health background.
Yes, I mean, and I understood what I was reading, and and the costs, and just trying to figure it out. I can't tell you how many options that there were. And I just ended up defaulting to the insurance that I had because I was overwhelmed.
Well, we had a interesting discussion yesterday afternoon about the implementation of the ACA here in Louisville. And we have navigators, people that help people try to make the right choices. But then you also have the insurance agents also doing the navigation work. And so people are in a line in the grocery store, and they either end up with the navigator, who is not allowed to be acting as an agent of the insurance company, and then you have people get in line with the agent who really doesn't understand the other aspect. And then the software is written that once you get in one line or the other, there's no ability to interact. It's amazing that given the complexity of communications with people and trying to get them signed up, that it worked. People actually got signed up. Now there's a lot of immigrants who got signed up where they really don't know if they qualify or not, but they got signed up. And there are a lot of cases that were opened and never finished. Plus you have to spell somebody's name exactly correctly. And so if you start and you can't complete it, and then you come back and you try it again and you use a different spelling for the name, that's the second one. And you come back because you can't get through and you do it a third time, you have 3 people who are actually just one person. And of course the calculator in California didn't work exactly right, so they think they enrolled a lot of people who didn't qualify. And what happens to them? They think they have insurance. Should be taken away from them because they didn't meet the definition of 138% poverty. And what happens as people move in and out of poverty? How do you deal with that? Surprised it works, given all the things that can go wrong. And I just love the media judging all of this simply by the number of people who are enrolled. Just because they're enrolled doesn't mean it's a success. I mean, what are you measuring after all? What happens to these people? In Kentucky, you got people say, I have 2 cards. I had a safety net card, and now I have this other Medicaid card. Which one do I use? Where do I go? What do I do? I usually go to the emergency room with my safety net card. That's my healthcare place. Well, the emergency room doesn't want you anymore because every time you go to the emergency room and it's uncompensated care, hospital has to pay for it now. Safety net funds are going away. It's complex. Also, people don't like the individual mandate. You must have health insurance or you pay a fine, and the fine will get worse. It starts to double. It starts to increase, and most people don't know that. Large businesses have to pay an assessment if they don't insure employees. And insurance companies cannot have lifetime limits on health coverage anymore. They can't cancel policy of patients when medical costs rise. And they can't spend too much on the administrative side of doing their business. A population perspective. So there's this other thing besides the Affordable Care Act, and that's Healthy People 2020, which looks at things from a population perspective, not a healthcare perspective. And the question is, when you're thinking about population health, how do these two things fit together? How do you think about them? It includes metrics on disease prevention and health promotion. The 2020 plan does. It's really worth reading. There's a website for it, and understand the details of it and how it might apply to wherever you are. It's the first plan. There's a plan 2000 every 10 years, 2010 plan, now the 2020 plan. And Louisville did one called Healthy Louisville 2020. The state has done one also. But the important point is that it emphasizes the importance of the social economic factors in health. If you're poor, you don't live as long. If you're poor, you have more complicated health problems. Even if you work in a big organization, the CEO, the people in the C-suite, live longer than the people on the assembly line. Called the gradient of health. It's been written about, it's been studied. It's quite simple. As I say, if you live on the east side of Louisville, you're going to be healthier and live longer. If you live on the west side of Louisville, you're not going to live as long. Every community has an east end and a west end. There are some cities in the world where there is no east end. It's all west end. Everyone is so damn poor, you have no idea how, and they don't live very long. They have a true health pyramid. A lot of young people who don't live very long, so you have a nice pyramid. We have this. Economic stability, education, social, community context, health, healthcare, the neighborhood, the built environment. Those are all things now that if you're expanding your thinking about population health, these are things that you have to consider. Health in all policies. There's a nice guide, Health in All Policies, a guide for state and local governments. It lists the 5 critical elements of health in all policies, which is promoting health equity and sustainability, supporting intersectoral collaboration, benefiting multiple partners. As Stephanie said, let's all talk. Let's share. Let's build relationships. Let's help each other out. That's a network. If you think about that network and saying, what are the policies in my organization or what I do that impinge upon health? What are they? What might they be? How do I think about health in all policies? How do I think about health in my organization and my stakeholders and the people I work with? How do we think about health? Multiple partners. How do you engage stakeholders? How do you create structural and procedural change? And how do you actually do collaboration? Leaders come from everywhere. If you want to transform communities and look at health status, we need to engage everyone, and we need to develop collaborative leaders. And they can come from anywhere in a community. There's an interesting book by Mike Levitt and Rich McEwen called Finding allies and building alliances. And these people will come together if there is a painful problem that everyone has that no one can solve by themselves. People will come together, actually work together. Even though they come from different organizations, they will all come together to solve that problem.
Do you think,
It happened.
do you think Ebola and
Yes,
what we've been
that's
doing?
another example. We know it works if we have an earthquake, we have a flood, we have a tornado. What happened? Everyone comes together. Everyone puts aside all their differences, and they work in taking care of the victims, cleaning up the mess, and getting the community back in order again. Extreme example, but that's an example when people, because of the pain, will come together, will collaborate, will get engaged, will help each other, will put all differences aside, because it's a community that has a problem, and they're a member of the community, and they want to fix it. Network leadership's different from organizational leadership. If I'm the CEO of a company, I can demand that things get done. If I'm in a network of multiple organizations, I don't have that power. I have to lead in a different way. I have to be a facilitator. I have to be a convener of stature. I have to earn people's trust. If they don't trust me, we're not going to get anything done. But you can learn network leadership. In a network, you can't require people and organizations to come together. You have to do it differently. You use trust, persuasion. You work with key people. They learn to trust you over time. You can call on them when a need arises, such as a disaster in a community or a really awful problem that's going to cause economic collapse. It can be learned. The problem is when you talk about collaborative networks, the terminology is kind of messy. There's alliances where you're really coming together for a mutual benefit. There's the word coalition. You go into Google and say, what is the difference between alliances and coalition? And you'll see some interesting stuff written. All you do is have to type it into the Google search engine. It's a whole bunch of stuff you can read about alliances and coalitions. It's interesting in public health, we talk about partnerships. Maybe coalitions, but please don't use the word alliance. Alliance sounds like it's a business. Now, the businesses love the word alliance. There's organizational networks. I assume that the Association of Engineering is an organizational network.
Right, the Association Engineering Summit.
Right. There's social networks. There's social media. There's Twitter. There's Facebook. There's LinkedIn, which is sort of business, but it's also social. And then what Levitt and McEwen talk about is the value alliance, where there's such pain that everyone's willing to come together because they have a value of coming together to accomplish something that will relieve the pain. That is another way of showing it. Power, money, trust. If you want to achieve a goal, you have to figure out as a network leader how to do this. There are limitations, though. If you're leading through power, it's hard. Getting new laws and regulations passed, forcing people to do things they don't want to do, That's hard to do. You can spend a lifetime trying to do that. You can lead through money or incentives, but there are a couple things here that you have to worry about. The tragedy of the commons. Anybody know what that is?
Some people give stuff, some people don't.
Yeah, you have a resource. Example it's given is you have grazing land. Some people own cows. Some people own sheep. The sheep eat more grass than the cows. And the sheep go in and eat all the grass. The people that own cows, there's no more grass. So-called tragedy of the commons. And so it's actually a tragedy of regulated resources, actually. And, you know, there's cognitive biases for this as well. If you're leading through trust, it takes so long to build trust, but you can destroy it in seconds by saying something stupid or doing something stupid. You can measure and manage trust. You can manage social capital. You can realize that trust takes years to build. You can manage bonding, bridging, and linking, which is what Stephanie was talking about. You want to avoid groupthink, where everyone begins to believe what it is they're doing, and they then start to suppress any other outside opinion or anyone that has a different thought, questions what is being done. If that gets shut out, you have a kind of situation called groupthink, which is also dangerous. You can use information technology to lower transaction costs, but you might in fact increase the complexity of what you're doing. The idea is you want to minimize complexity, and you have to consider transformational and transactional leadership styles. There are all kinds of opportunities for network leadership in population health services, health and all policies, population health research networks, certainly in clinically integrated networks. It's a big requirement in community health management systems. Those are all opportunities for network leadership. So, jumping ahead to the other theme in the book, health and all policies. The idea is that there are areas other than health services which actually have a greater impact on people's lives. Having a job, being educated, having transportation, having food. All of those things have a larger impact on your health than all the healthcare services in the world. Our health depends on what we have, where we live, what we eat, so forth and so on. It provides a concrete pathway to actually health promotion. So, how do you identify the problem? What are successful strategies? What are common goals? How do you change the context to promote health and wellness? And try and get some policy change. We spend 18% of our GDP on healthcare. What do we get for that? Well, life expectancy of 76 years for men and 81 years for women. Most experts think that we're spending too much money to get that. Other countries can get this by spending half of what we spend. We're about 34th on the list of countries in terms of what we spend for what we get. So, what interventions should be introduced to achieve maximum benefits in life expectancy and quality of life? Should the focus be on technology? Do we need a proton beam accelerator in every community. Protein beam accelerator can be used to treat prostate cancer. It costs millions of dollars to have one of those. So if one hospital gets one in a big metropolitan area, does every other hospital have to have one so they can compete? Drives up the cost of care. For what?
In your discussion so far, have kind of been avoiding the elephant in the room, what I'll call two myths. That is that we have the best medicine in the world here.
Right.
You just pointed out we have the most expensive, but not the best. And the second myth is that verbal grenade socialism, that really you're arguing very persuasively we ought to have a single payer system rather than the complexities that you described. Do you see a way that we'll ever evolve to that rational approach to healthcare in this country?
We believe in both market justice and social justice simultaneously. Our business model has not changed. Our business model has been the same in healthcare for years and years and years. It's an arms race.
It developed because of the World War II in terms of,
Right.
Of having companies sponsor healthcare
Right.
costs.
Right.
And that puts us at a competitive disadvantage internationally now in the global economy. And it leads to these complexities of the Affordable Care Act and so forth.
Have you read the book, Who Killed Healthcare? You should. You see the movie, The Orient Express? Remember the passenger on the train died? And the question was, who killed the passenger on the train? And the conclusion, everyone. We have all killed healthcare in this country. All of us, one way or another. The blame can be spread to all of us because there's a lot of money on the 50-yard line. And until the business model changes, the game will continue. You disagree? You disagree?
Unfortunately not.
It's terrible.
Because of the insurance industry and the power of the insurance industry holding all the money, that
Right.
it's very difficult to change that model.
It's really sobering when you think about it. What's the definition of insanity when you keep doing the same thing over and over again and expect a different outcome? That's insanity.
Can I add another layer into the when you say, like the Orient Express, that everyone's responsible?
Mm-hmm.
I think we spend a lot of time blaming folks like the insurance industry and healthcare and what it costs to have a nurse or a physician, et cetera. You know, I find it also, I think it is everyone though. I think it's Staples. Why does it cost me $3 to buy a notebook at a hospital and I can go to the store and pay 59 cents?
Mm-hmm.
So when we talk about overall health care cost, it's not just limited to the cost of providing the actual physical care, but really rendering the care. For me to buy a printer is $1,000. You can get one at Staples for $8.
What we're trying to do is, if I can take that a little bit further, we're trying to reduce the transaction costs in health. If you enrolled somebody, you know, on a phone with a paper form, say it costs $15 per person, using fax machines, telephones, calling. You can drop those transaction costs if you're able to do it all electronically. You can get rid of that $15 and drive it down to pennies. And since in healthcare we move so much information and money to transactions, in the network we're moving information and money. And if you can drop the transaction costs, which is what AARA high tech was all about, then you achieve efficiencies. If you can then become more effective in how you do that, it's not just getting rid of paper or automating the process, it's actually figuring out how to become more effective in that process. And then you start putting together things that you were not able to do before, so-called integration. If you're able to work through that, you can drop transaction costs. But there's no free lunch ever, because the simplicity of speed and dropping transaction costs from $15 per person to pennies per person, the complexity increases on the backside. Somebody's got to manage all that. Someone's got to deal with all that. So just because you reduce transaction costs, your complexity costs go up, managing complexity. Okay. There are some successful strategies for using evidence-based approaches. They're written up in the book. The important thing here I want to make is the health impact pyramid. As you begin to think about increasing population impact, it turns out that the key thing in the bottom of the pyramid is social economic factors, which we talked about. Frieden's published this, there's a reference. As you deal with individuals and the individual effort, it increases, the effort increases as you deal with not down here, but up here, and counseling individuals, clinical interventions on a personal basis. Those things are, it's a complexity perspective. So there are some common goals. Identifying key health status indicators, providing education, having a government plan to design and develop better, safe, walkable communities, making healthier food options available. These are all things that can be done in a community. They all affect health, but you just don't see it. And it takes a long time before you begin to see the effect. We covered that. There's a nice website to look at community prevention services and things that have been established through the National Prevention Council. This is a nice slide showing the National Prevention Strategy. I'm not going to walk through that, but that's in the book. It's in the PowerPoint presentation you have. So there are policy implications that affect the environment, the economy, the education system. And there are policy implications. Basically, transportation planners should look at safety. Social administrators should think about including health in the curricula. Local governments should recruit businesses that want to have the workplace a safe place so workers can be healthy and be able to work. And when resources are scarce, one has to start doing setting priorities with respect to the high impact areas. And shared goals and metrics will be a critical factor. So health and wellness is the name of the game. I want to talk really, in the few minutes I have left, about technological innovation. Basically, those are just a few examples of new technologies. How many of you remember the movie The Graduate? What did he say to Dustin? Young man, the future's plastics. What I would say today, young man, the future is sensors. Sensors, we have sensors in our cell phones. You can put sensors under the bed. You can get the blood pressure, know if the patient gets out of bed. We can do public health or population health surveillance looking at sensor data. That's coming down the road. That will be exciting. We have kiosks. We have wireless communications. My daughter has a sensor she wears, wireless communication to her pump. She eats something, her blood glucose goes up. The sensor tells her to pump. It'll beep if her glucose is going up too fast or it's dropping too rapidly. Technology, wireless communications, better control. Dad, my diabetes is just an inconvenience. There are a lot of challenges for thinking about public health informatics. And this is all about new businesses, developing new ideas, and doing new things. Remember, we're not going to change health either technologically or the healthcare business unless we look at the business models and figure out how to change them. Otherwise, we'll just go down this road to insanity. It requires collaboration with patients, purchasers, payers, providers, practitioners, and people that have an interest in population health. There are statewide based frameworks. There's the idea of health record banks. Basically, those are the kinds of things that we want to do. We want to collaborate for population health from a technology perspective. Finally, I think this is the last slide. Better care, better health, lower costs, the triple aim. But also thinking in the context of Healthy People 2020. You have to think about both. Am I okay? All right. Any last questions? Did I give you something to think about?
I was going to say you gave us kind of a little bit of a tidbit. Now we get to go to the buffet and really hardwire and digest. So very good job, Dr. Esterhay.
Thank you.